My aim today is really to tell you a story about our experiences with implementing de-identification or anonymization in practice. We built some anonymization software about 15 years ago. We started a company 10 years ago, and the anonymization software was really to help researchers at the Children's Hospital, where I was based, to share data with researchers and with external partners. And about a year and a half ago, the company was acquired by IMS Health, which is the world's largest health data broker, which has now changed their name to IQVIA. So we're part of IQVIA. My company is Price Analytics, and we're part of IQVIA, which is the merger of IMS Health and Quintiles, which is Quintiles was the largest contract research organization in the world. They ran clinical trials for pharmaceutical companies. So I'll start off by describing our approach to anonymization. Give you just an example of how we've deployed this anonymization technology in practice. The benefit, of course, of being part of a large multinational is that we are able to deploy our work and our software and the results of our research globally, right, into sites around the world and some very large installations and health systems around the world. But let me start off with some of the basic background. So our view and others' view of anonymization is that identifiability falls on a spectrum. At one end of the spectrum, you have identifiable information, and at the other end of the spectrum, you have completely anonymized information. And you can divide the spectrum into four rough categories that match the definitions in the GDPR, the General Data Protection Regulation. So as you move from identified data or identified information, as you make observations to the data, you then move to pseudonymous information, and as you apply more changes and more controls, you have this concept of strongly pseudonymous information. And then there's this hypothetical or threshold point on the spectrum that differentiates personal information from anonymous information. And once you cross the threshold, you have anonymous information, and that's no longer considered personal information. So in order to implement anonymization properly, you have to be able to measure the risk of identification. You have to be able to measure where you are on the spectrum. You have to be able to set thresholds. So it's a very quantitative approach. The measurement of the risk of identification consists of two parts: data risk and context risk. So data risk is essentially a statistical estimator of the ability to match a person with the data correctly. And there are different attack models that you can model or account for in this estimate. And then the context is essentially the security and privacy controls and contractual controls that you have in place. So if you're sharing data with a researcher, you have to take into account the security controls, the privacy controls, and the contractual controls that researcher or that researcher's institute has in place. And we've built a model to assess these controls, quantify them, validated this model over the years. And so this is essentially a conditional probability of the data risk is conditional on the context risk to give you your overall risk. And once you have your overall risk quantified, then you can compare it to your threshold to decide if your personal information, you have personal information or not personal information. And if you're above the threshold, then you apply various perturbations to your data, or you can change your context. So there are two ways to manage the risk. You can change the data, or you can change the context. In practice, you do a little bit of both. So that's the basic model for anonymization that we have developed. It's not a controversial model. If you go look at the Cisco disclosure control literature over the last 40 or 50 years, that's essentially the model that's been embedded in there. And we just formalized it so that it's It's a repeatable process with checklists and scoring algorithms and so on, so that it can be implemented in a consistent manner and it can be automated in software. So that's our anonymization approach. So I'll just tell you a little bit about some of the implementations we have, some of our experiences putting this in practice over the last few years. So we do a lot of work with pharmaceutical companies, with IT companies, technology companies, health IT and non-health IT, as well as health systems. There are really two modes for implementing anonymization in practice. One is to anonymize data feeds, and the other one is the discrete anonymization of data sets. So for data feeds, there are four typical scenarios. I think the first two we cover. This is the identification or anonymization of source, and then setting up a trusted third party to anonymize the data that's coming in. So the identification of source is where the anonymization software, the identification software is installed at the EMR vendor, or within the electronic medical records, installed within pharmacies, installed within clinics, to anonymize the data at the provider site, and then it's sent to whoever's going to do analytics on, whether it's a researcher or a company or whatever, so that the data is anonymized before it leaves the original site. This is an example. This is a Canadian example. One of the largest EMR vendors in Canada. We worked with them, where we implemented this risk-based anonymization scheme on-site in the data center, and every week the database is anonymized and then sent over to an analytics company to do two examples. And we were involved in post-marketing surveillance of adverse events for certain types of drugs, and to have prescription pattern analysis. We did some work in public health as well, with the community surveillance project with the public health agency. But the point is, you have up-to-date EMR data. This is a bit of data, about 1 million patients there right now. So the full database is anonymized. So this includes all the clinical data, billing data, prescription data, and lab data, and scheduling data as well for appointments and so on. The other scenario is setting up a trusted third party. This is really important because a lot of organizations don't have the IT capacity to implement anonymization software. So you have a lot of small clinics, small pharmacies. Remember, this is being deployed in many countries around the world, in many locations. So a lot of sites, suppliers or sources of data don't have the capability to implement and maintain anonymization software at source. So we set up trusted third parties to receive the data from the sources, anonymize that data, and then send it to further for analytics. Setting up a trusted third party is actually quite complicated, depending on which country you're in. So, for example, in France, you're processing personal health information. The site has to be certified by has to receive certain certifications. Whereas in other countries, the certifications are not necessary. You just need to have contracts with all the suppliers. So, setting up these trusted third parties is let's say, a heterogeneous exercise depending on the jurisdiction. And of course, the example is getting data from pharmacies, where prescription data is collected from pharmacies, passed through a trusted third party, where all that data is anonymized and then sent onwards for further analysis by different types of users. And this is, again, a continuous data feed that happens on a regular basis. And depending on the type of pharmacy, whether it's retail or specialty pharmacy, the volume of data and frequency will vary. Some very frequent, some not very frequent, some very large data sets, and some very small data sets. The other type of scenario, of course, are discrete anonymization. So these are not data feeds. So a classic example is sharing data with researchers. The example I will mention here, which I think is interesting, is ASCO, the American Society for Clinical Oncology, and the Cancer Link project. So ASCO is vision is to collect data from cancer clinics across the U.S., pull the data, map it to a common data model, and then make that data available to researchers for analysis and through the portal. So that data, the intention is to cover about 30 million lives when it's when the whole system is rolled out and all the clinics are on the platform. The objective is really to create or set up a local health system with the vision of providing some of these capabilities at the point of care, where physicians are able to query this large anonymized database to find similar patients who have similar profiles, to using similar treatments, and then look at their outcomes to determine what are the potential outcomes for different courses of treatment. This is a good example of, again, ongoing large-scale anonymization of cancer data for different types of cancer. So let me talk about lessons learned, because I think this is really where research perspective, some interesting things can look at from doing these types of projects of discrete data sharing based on individual researcher requests, for example, the ASCO or continuous data feeds. So from a technical perspective, the biggest challenges for anonymization, I'll just kind of highlight three main things. One is knowability. So when you have such complex data sets with millions or tens of millions of lives, and the data models are very, very complex, they can have hundreds or more of tables, you have to build an adversary model that makes sense. A lot of the published work on anonymization does not have a very complex, or I would say not a very sophisticated model of the adversary. But if you model the adversary in more detail, you're able to get much more precise estimates of the risk of identification. So one of the things you can model is knowability, which is to what extent is certain information knowable by an adversary. So certain detailed information is not going to be knowable by adversaries who are trying to attack the data and in order to use that information for identification attacks. Old information is less knowable than recent information. People's ability to recall details increases over time. So for certain types of attacks, this ability to recall is important. So being able to model knowability for different types of information, for dates, for diagnoses, for example, is important if you want to have a more precise adversary model when you're estimating the risk of re-identification. The other key thing is correlated information. So again, when you have a large database of data, clinical data, you have, I guess, two kinds of things. One is these databases are not normalized, so a lot of information is repeated in many different places. So you have to ensure when you're anonymizing that you're capturing all these repetitions, but also a lot of information is correlated with each other. So if you do not anonymize, if you anonymize one part of the data, you may information you try to anonymize may be recoverable by using the information that was made in the database. So as a simple example, we did some experiments with the ability of pharmacists to recover diagnosis and drug information from anonymized databases by hiding certain or anonymizing certain information and keeping other information. And the degree of recovery was pretty high. It wasn't actually related to that much related to experience, but nevertheless, the providers and specialists are able to recover clinical details even from partial information. So you have to be careful when you're anonymizing to be able to capture correlated information, ensure consistency in the anonymization, and then take that into account, of course, because you don't want to remove too much information, so you have to account for data utility as well. But being able to measure correlated information in an automated way reasonably well is important. And then the last challenge, again, technical challenge, is the ability to anonymize data in a continuous fashion, data streaming or incremental data. The challenge with that is if you already release some data about a patient, you want to be able to take into account what's already been released when you're anonymizing subsequent data about that patient, without having to maintain the full copy of the whole data set in order to deal with future data. So you want to be able to compute statistics from the data that's already released and use those statistics only to be able to update your risk estimates on an ongoing basis. So there's some models out there, but this is an interesting area of research as well. And certainly, if anyone is interested in working in those areas or is already working in those areas, I'd love to hear from you. In terms of practical implementation challenges, so we've done some. I mean, one of our large implementations is the government of Alberta. So Alberta has about 4 million citizens, 74 health databases across the whole province. These databases cover everything in the healthcare system, and so they're anonymizing all of that data, 20 years worth of data, and retrospectively and prospectively in order to anonymize it. So very, very complex data anonymization effort. So the kinds of things we've seen with anonymization, and you have the technical challenges, which is fine, but the biggest challenges are actually non-technical. One of them is the skills gap. A lot of organizations historically have used very simple anonymization techniques, either rule-based approaches, which we can demonstrate can be high risk, or they only pseudonymize their data. So we see a lot of that, organizations only pseudonymizing their data and releasing it with the assumption that that was sufficient. So there's a big skills gap between what has been done historically and risk-based approaches to anonymization. So this skills gap has to be bridged in order to be able to implement these types of anonymization techniques. Also, in a lot of places, there's been a history of unrestricted access to data, and when you start introducing anonymization techniques, there's a lot of resistance to change because it's not how things have been done in the past. So historically, researchers had access to a lot of data, or employees had access to a lot of data. When you start introducing better privacy controls and anonymization techniques, one of the barriers is you're changing the way analysts or individuals have been accessing data, and this change in operations always makes the introduction of any kind of privacy enhancing technology, for that matter, I think quite challenging. And then also we see a lot of times anonymization is demanded experientially, where you have one or two people who make a judgment call about how to anonymize data, and they were considered as the experts, and now you try to use an objective, repeatable way for measuring the risk and anonymization. And again, resistance to change, changing practices is always been a challenge. Coordination between the legal teams and technology. Again, you have to remember anonymization is a legal concept. Technology and change management and so on are really means to achieve a legal objective, to meet regulatory requirements. And in some organizations, getting the legal team and the technology team, the IT team, and the analytics teams to talk to each other is non-trivial, because historically they don't work together, they don't talk to each other very much, and having those two parts of the organization engage together to implement anonymization or any privacy enhancing technology also requires some work. And we also see a lot of homegrown tools for anonymization. Sometimes we see people who implement their own encryption algorithms and have used those. We've seen a lot of things. But if you have a homegrown tool that has been in use for some time, and upgrading that to something more advanced that uses different approaches, also change management. It takes a lot of time to change an organization from using existing technology to a new technology. So the biggest challenges in deploying, in our case, anonymization, especially large scale, complex organizations is really dealing with change management issues and less with having the best technology or the most advanced technology. Of course, that's important, but that gets overwhelmed by all the change management and implementation issues. So I'll leave it at that and see if you have any questions.